Hello dear students, in this session we will start with MCQs of ENT. So taking the very first MCQ, in which an old male patient presented with merciful anosmia, wide roomy nasal cavity with formation of crusts and nasal obstruction. What is the diagnosis? Now here, if you look, there is one term, that is merciful anosmia. Now, anosmia means no smell sense. And why we call it merciful? Because what happens, there is emanation of very bad smell from the nostril of patient. There is emanation of very bad smell from the nostril of patient, and since there is anosmia, he or she could not smell that, and whenever they meet with anybody else, they all ran away. So they are not able to understand why people are running away from me. So that is because of this anosmia. And since they couldn't understand the reason why, so this is known as merciful anosmia. So this merciful anosmia, yes, everyone is right. Everyone is right. So this merciful anosmia is a typical feature of atrophic rhinitis. There is formation of crust within the nose. The nasal cavity is very wide. We call it roomy nasal cavity. And of course, the classical merciful anosmia. So this is atrophic rhinitis. So this is merciful anosmia. Now going forward to the next question, an elderly patient, bilateral neck swellings, temporoparietal neuralgia, and unilateral conductive deafness. So what does this suggest? Very good. This is a classical description for nasopharyngeal carcinoma, or what you call NPC, and there is a Trotter's stride. What are the components of Trotter's stride? U has been already given in the question. One is temporoparietal neuralgia. Very good. You absolutely right. There is palatal palsy and conductive hearing loss. Very good. So these are the three contents in the Trotter's stride, very suggestive of nasopharyngeal carcinoma. So the moment you have this kind of presentation, it's very easy to make a diagnosis of nasopharyngeal carcinoma. And here you are getting this word also, like bilateral neck swellings. What is this? These are actually enlarged lymph nodes. So this is a classical description for nasopharyngeal carcinoma, or what you call NP. Then moving ahead to another question, unilateral nasal obstruction with blunt stage charge in a child. Any idea what is this? Yes, Raghu, you are absolutely right. If in a child you have this kind of history, then it suggests there is neglected foreign body. So a neglected foreign body will have this kind of presentation, unilateral nasal obstruction with blood stained discharge. For a child, always remember neglected foreign. Yes, Aninda, Nilesh, Raghu. Yes, foul smelling. Yes, very good. So this is a typical presentation for neglected foreign body in a child. Now, which of the following is not seen in Meniere's disease? Which of the following is not seen in Meniere's disease? Yes, anyone? Yes, Raghu, Aninda, Shivendra, everyone is right. The triad of Meniere's disease is also known as endolymphatic hydrops. We will see there is vertigo and there is tinnitus and there is sensory neural hearing loss. So the answer comes out to be loss of consciousness. It is not a feature of Meniere's disease at all, right? So vertigo, tinnitus is ringing of ears, and sensory neural hearing loss. Perfect. So this is Meniere's disease. Then next question, a patient hears better in noise. Now what is this known as? Yes, perfect. Raghu, you are absolutely perfect. So a patient hears better in noise. This is known as paracusis willisii, and this is a feature of otosclerosis. Right? So in otosclerosis, we will find paracusis willisii, and that is really patient hears better in noisy surroundings. That's so because a person or the fellow who are surrounding the patient, because they are in a noisy environment, so they will speak a little louder, and the patient takes the advantage of that, and therefore he is able to listen them in a better way as compared to the usual way of talking, right? So in noisy surroundings, patient hears better, but if the silent are quiet and if people are speaking in a low volume, then it is very difficult for the patient to understand things. So this is known as paracusis willisii, a very characteristic feature of otosclerosis. Next question. 55 years old male, a known case of diabetes with poorly controlled blood sugar, developed right facial nerve palsy, and also is having pain in right ear and discharge from right. On examination, granulation tissue was found in the external auditory canal. What this suggests? Everyone is right. Yes, yes. So this is presentation of malignant otitis externa. Now here one should remember few things about malignant otitis externa. We are getting this word malignant here, but this is actually misnomer, right? So it is not a malignancy, right? It is not a malignancy. It is just that the infection is very severe. So we have used this word malignant, but it is not a malignant entity at all. This is most commonly caused by, yes, pseudomonas, rightly said, and especially seen in cases of poor blood sugar control in diabetic mellitus or immunosuppressive condition. So in those conditions we see this infection of the external ear, and since this infection is very severe, so we use the word malignant otitis. Yes, Raghu, you are absolutely right. It is not a cancer, and therefore this word malignant is actually a misnomer, right? So this is caused by pseudomonas, especially in immunosuppressive states or poor sugar control in case of diabetic, and it might involve facial nerve as well. So this is malignant otitis externa. Now, can anyone tell me what bacteria is responsible for causing simple otitis externa? Anyone? Because malignant, it is related to Pseudomonas. Which bacteria is associated with simple otitis externa? Anyone? This is Staphylococcus. So this is Staphylococcus aureus. Commonly, it is Staphylococcus aureus. Now, what is this term? Chronic suppurative otitis media. Here, if an acute infection is not treated properly, it might go into CUSOM. And again, CSM can have two presentations, safe and unsafe. Right? Safe and unsafe. In safe, the perforation is central perforation, and in unsafe, it is, you can say, marginal or equiantral. And there are high chances of cholesteatoma in unsafe variety, and this cholesteatoma is actually a bony erosive. Right? Yes, Ghosh, you are absolutely right. Equiantral is unsafe actually. Okay, so this is in short about CUSOM, that is chronic suppurative otitis media. Now going onward to next question. Elderly male presents with hearing loss, pulsatile ringing sound in the ear for the last 3 years, and on otoscopic examination we can see a pulsatile reddish mass behind the tympanic membrane which is intact, and this mass blanched and stopped pulsating on applying pressure with Siegel's pneumatic speculum. Most likely diagnosis. Very good, Raghu. This is Glomus tumor. So this is a vascular entity, and the characteristic feature is a pulsatile reddish mass behind the intact tympanic membrane, and if we put pressure, it blanches. Blanches means it becomes pale. So this is a classical presentation for Glomus tumor. Very good. Now next question. An elderly diabetic male with uncontrolled sugar presented with dyspnea, fever, generalized malaise, and respiratory rate was increased. Nasopharyngeal swab for RT-PCR was positive for SARS-CoV-2, and later on he developed swelling in the periorbital area bilaterally with proptosis of right eye. Which microorganism can be the reason? Yes, the description is for which condition? Clinical presentation is for Mucormycosis. Of course, the responsible agent is Mucor. Thank you, everyone is right. So this is a classical presentation of Mucormycosis, especially related to COVID infection, and here we can see involvement of the periorbital area along with proptosis. Now what is this proptosis? Projection of, or you can say prominence of the eyeballs, that is known as proptosis. So this is mucormycosis, which is treated by amphotericin B injections. So coming on to the next question. Multiple perforation of tympanic membrane is characteristically seen in. Yes, anyone? Multiple perforation of tympanic membrane. This is tubercular otitis media. So in cases of tubercular otitis media, you can see this is one perforation, this is second, here you can see the third, This is multiple perforation of panic. This is classical for tuberculosis. So tubercular otitis media. Now, what we see in case of serous otitis media? Any idea what we see in cases of serous otitis media? Serous otitis media, which is also known as blue ear or otitis media with effusion. Yes, very good. So this is actually air fluid levels. Yes, we will see air bubbles. So air fluid levels will be seen. Very good. And in case of acute suppurative otitis media, what we will see? Cases of otoscopic examination. Any idea? We'll see a congested and bulging tympanic membrane. Very good. Right? So congested and a bulging tympanic membrane. In cases of CSM, we will see a perforation in the tympanic membrane. It can be in central or aticoantral region. So this is how we can see either in so few words about typical appearances of otoscopic examination options. Then next question, a patient had a history of head injury and he developed unilateral conductive hearing loss, but tympanic membrane was normal and it was fully mobile. Now, what could be the cause of this conductive hearing loss? Anyone? See, whenever we are discussing conductive hearing loss, very good, everyone is right, So whenever we are discussing conductive hearing loss, there are a few points which you should remember. Number one, either there can be a problem in the tympanic membrane or problem in middle ear cavity or problem in ear ossicle. Please remember at least these three important reasons for conductive hearing loss. So tympanic membrane, middle ear cavity or ossicle. Now, since here the tympanic membrane is normal and fully mobile and there is a history of head injury, so it goes more in favor of the dislocation of the incudostapedial. So this is how we can just, by the principle of exclusion, we can reach up to the answer. There is history of injury, so that what is more in favor of the disarticulation of the middle ear. So this is just because of head injury. ASM can also lead to conductive deafness, but there will be a history of fever, heaviness, pain in the ear, right? So this is eighth nerve injury that will always lead to sensorineural hearing loss, right? So this is how we can just rule out the options and we can choose the best possible answer. Yes, everyone is correct. C seems the better answer here. Next question, most common clinical presentation of acoustic neuroma, which is also known as vestibular schwannoma. Now, this is a tumor of cranial nerve 8th. So, therefore, the better answer would be cochleovestibular symptoms. Right? It is a tumor of cranial nerve 8th, so it will present with cochleovestibular symptoms. Next question. A diabetic lady presented with distraction of the nasal portion of her face, and she had a past history of COVID-19. So, what drug can be given? And I think most of you can make a clear-cut diagnosis that this is a case of mucormycosis. So, post-COVID, yes, everyone is right, perfectly right. So, mucormycosis, we can give injection amphotericin B. Yes, right. Raghu, Chiki, Shiva, everyone is right. So, destruction of the lateral part, post-COVID mucormycosis, and should be treated by injection amphotericin. Now, this we have already discussed before, not a component of Trotter's pride. I think everyone should be able to answer this. We have already discussed this. Answer is facial nerve palsy. So, it is not a, it has nothing to do with Trotter's pride. So, we can see soft palate immobility is actually is nothing except palatal palsy, temporoparietal neuralgia, and unilateral conductive deafness. So, classical triad for nasopharyngeal carcinoma. Please don't. Right. Now, stylalgia may present with ear pain. Which nerve may refer the pain to middle ear? Anyone? Yes, Raghu, you are absolutely right. This is glossopharyngeal nerve, and glossopharyngeal nerve is actually the nerve supply of middle ear and medial aspect tympanic membrane also. So, stylalgia, one condition which is also known as Eagle's syndrome, where there is elongation of the styloid process. There can be irritation of the glossopharyngeal nerve, which can refer the pain to the middle ear. Right? So, this is Eagle's syndrome, stylalgia. Next question. A 5-year-old child presented with nasal discharge and nasal obstruction. There is history of recurrent infections, and the child was breathing from mouth with a high arched palate. What can be the diagnosis here? Yes, everyone is correct. Shivendra, Ganesh. This is adenoid hypertrophy. So, this is adenoid hypertrophy, and the child is breathing from mouth. It means the adenoids have enlarged and they have obstructed the airway. So, the child finds it's very easy to breathe from the mouth. So, this is adenoid hypertrophy. Now, the important thing here is that adenoid hypertrophy, here if the child is breathing from mouth, it means there will be no proper aeration of maxillary sinus right? And this will lead to poor development of maxillary sinus or the maxillary prominence. Right? This is number one. Number two, these patients can have an associated otitis media. Which type of otitis media? This serous otitis media. So these patients, they can have glue ear, right? And therefore, whenever we are treating these patients, we have to take care of this serous otitis media also if it is present. So for that, we need to do maringotomy with a chromate tube along with adenoid. So we have to treat the condition as a whole. So if there is adenoid hypertrophy, do an otoscopic examination. If you find there is serous otitis media, it has to be treated simultaneously, right? Now this is very important because if you neglect adenoid hypertrophy and the child continues to breathe from mouth, later on he might have very depressed kind of nose because the LR nasi are not used properly. Then he will have adenoid facies, proper adenoid facies. So this is very problematic and should be addressed timely. Yes, Raghu, you are absolutely right. Serous otitis, glue ear, perfect. So treatment wise, we need to remove the adenoid. Plus, if there is glue ear, we have to address that as well. So laryngotomy, here treat the whole complex as one entity. Next question. Appropriate investigation for JNA, juvenile nasopharyngeal angiofibroma, and Raghu said yes, you are right that biopsy is contraindicated, but the best answer is TCT head. And here we will see one clinical sign that is known as Ullmann-Miller's sign. Now what we'll see here, suppose if you are looking you are having a transverse section, so this is suppose the outline of maxillary sinus. So what will happen, the tumor which is present here, it will push the posterior wall of the maxillary sinus. So you will see something like this. This is the Ullmann-Miller sign, which says that there is a thing of the posterior wall maxillary sinus by the. So we can compare it with the other side. Yes, Ullmann-Miller sign, very good, Ganesh, right? So CCT is best, and of course Raghu pointed out very nicely that biopsy is contraindicated since it is a highly vascular. Don't go for biopsy, otherwise it will keep on bleeding. So this is juvenile nasopharyngeal angiofibroma, which is better visualized or evaluated on CCT head. Yes, very good, Aninda. There is anterior bowing of posterior. You can call it perfect. Next question. Causative agent for NPC. I think everyone knows this. This is Epstein-Barr virus. No, this is very interesting. Weber test, conductive deafness. Nilesh, Iki, Ninda, yes. All of you are right. Extreme, yes, absolutely right. sound louder in diseased ear. Now here, what we do actually in Weber test, we tap the tuning fork and we will place it on the center of forehead. Tap, place, off, and then you need to ask in which ear the patient is hearing better, right? Or in simpler terms, where is the lateralization? Is it going to one particular ear or it is same on both the sides? Ask for lateralization, if any. Right? In a normal person, normally no lateralization. It should be heard equal in both the ears. But suppose if the patient is having problem in right ear, and when you do Weber test, the lateralization is towards the diseased ear, then you can say that in right side there is conductive hearing loss. So diseased ear, lateralization, conductive hearing loss. If the patient is complaining of problem in the right ear and you find that lateralization is going on to the left side, it means there is sensory neural hearing loss in the. So lateralization, same side CHL, opposite side sensory neural hearing, right? So if the patient is coming to you with some deafness in right ear, you do Weber test. If the lateralization is going to the right side, you can say that this deafness is probably conductive hearing loss. But if patient is having deafness in the right side and lateralization is going towards the left side, then you would say that on the right side there is sensory neural kind. So based on Weber test, we can ascertain what kind of deafness patient is having. So this is, if conductive deafness, same side, sensory neural deafness, just remember this man. So if we look at the diagram, we are keeping the base of the tuning fork somewhere here like this, and then we tell the patient to close the eyes and tell us which side sound is going more. We are actually checking for lateralization. In normally it should be equal on both sides, right? So patient will say, I'm having the sound both same type in both the ears. But suppose if there is problem in right ear, okay? Suppose if there is problem in right ear and the lateralization is going also onto the right side, then you will say, then in the right ear there is conductive hearing. Now, if suppose the problem is the right ear, but patient is saying that I am hearing better or I am having lateralization in the normal side, then you will say that the right side is having sensory neural hearing. So this is how we interpret the Weber test, whether a person is having conductive hearing loss or sensory neural hearing. So next question. 16 years, male, epistaxis, red mass around the nostril. Yes, very good. So this is JNA. The moment you find this particular presentation of an adolescent male with fullness in cheek, recurrent epistaxis, straightforward, make a diagnosis of JNA, juvenile nasopharyngeal angiofibroma. So there should be no confusion in this particular entity. Now again, one more tuning fork test, Rinne test. Rinne test is positive in, yes, anyone? Very good, Raghu, very good. So Rinne test is positive in normal ear. Yes, push, please. Everyone is correct. Now, what actually this Rinne test is? So, what we do in Rinne test, firstly, we tap the tuning fork and we will keep it over the mastoid, right? And we will tell the patient, the moment you don't hear any sound, please tell me. And as soon as the patient tells you that I am not hearing any sound, you will lift the tuning fork and you will place it in the front of external ear. And normally, a person should be able to hear the vibrations when it is kept in the canal or external auditory meatus. Now, when we keep the tuning fork over the mastoid process, we are checking bone conduction. And when we are keeping the tuning fork nearer to the external auditory canal, we are checking air conduction. So, in a normal person, air conduction is always more than bony, right? So, in a normal person, air conduction is more than bony conduction, and this is known as positive Rinne test. Number one. It means when the patient will say that I am not feeling any bone conduction, you will take out the tuning fork and you will keep it in front of the external auditory meatus. Normally, a patient should appreciate the vibration. But this is not only limited to a normal person. The same thing can also be seen in sensorineural hearing loss. In a person in whom there is sensorineural hearing loss, you will find that bone conduction is shorter and air conduction is more. So, air conduction is more than bony conduction. So, in both the cases, normal as well as sensorineural hearing loss, air conduction would be more than bony conduction, and you will say that the Rinne test is positive, right? So, if I say Rinne test is positive, then of course one condition is normal ear, or else it can also be sensorineural hearing loss. Okay? Sensorineural hearing loss related to the inner ear and the 8th cranial nerve. So, in both the cases, bone conduction will be less, air conduction will be clear. So, I think there is no confusion in this. For the time being, we are limiting ourselves to the normal ear and the sensorineural hearing loss case where the air conduction is more. Conversely, if there is conductive hearing loss, just reverse the scenario. In cases of conductive hearing loss, bone conduction will be more than air, right? So, in cases of conductive deafness, there can be perforation, collection of fluid in middle ear, or there may be disruption of ossicles. In all such cases, bony conduction will be more than the air conduction, and then we will say that our test is negative. Clear? Please remember this one. Now, based on Rinne test, we can take one more good question. Which of the following is not true for Rinne's? Now, you have to check which option is not true in relation to Rinne's test. Now, we'll take the options one by one. AC is more than BC in normal ear. I think this statement is correct. Yes, okay, so this is a right statement. We just discussed that air conduction is more than bony conduction in normal ear and also in sensorineural hearing loss. So, A and B options both are correct, and they suggest that it is a positive Rinne. Then coming to option C, BC is more than AC is conductive hearing loss. This is also true. Converse of what we have discussed in option A and B. So, bone conduction is more than air conduction in conductive hearing loss. Now, by the way of exclusion, we can say that the answer is option. Discuss what actually this option D is. Now here the condition is severe sensory neural hearing loss or dead ear. Now here what happens, there is no air conduction as well as there is no knee conduction. So here there is no air conduction, and yes, Raghu, you are absolutely right, absolutely right. So what happens actually, like suppose you are checking the Rinne's test. So suppose this ear is dead ear. Right? So there will be no air conduction, there will be no bony conduction, but when you will do bone conduction, patient will feel the bony conduction because of the transmission from the opposite side. Right? So it is just because the opposite side transmission can take place through cranium, and therefore your bone conduction will be more than air conduction. So bony conduction will be more than air conduction because the transmission of sound is occurring through the cranium, right? So this is wrong because in the affected side there is no air conduction, there is no bony conduction as such, but since it is coming from the opposite side, so this is false, and of course BC more than AC is negative. This is false negative. Very well said, Raghu. So this is false negative actually, and if you want to eliminate that, what you can do, you can simply cover this ear, right, with a box so that there is no concept of bony conduction, and this conduction which was occurring before, it can be eliminated, right? So this is a beautiful concept related to dead ear or severe sensory neural hearing loss, where usually there is no air conduction, no bony conduction, but since the bony conduction is taking place across the cranium from the opposite side, so it gives a false reading as if the bone conduction is more air conduction, and since we know that bone conduction more than air conduction is negative test, but here we are getting it in a wrong manner, so we will use the word false negative. Clear? So this is option D, which is wrong. It should be false negative, or you can say BC more than AC in dead or severe sensory loss. Clear? Next question. Hyperacusis is seen in all except. We just discussed one word, paracusis, and paracusis is a feature of otosclerosis. So in otosclerosis, please remember one term, that is para. There is no word like hyperacusis, it is actually paracusis, and we have already discussed what paracusis means. The patient hears better in noisy sounding. I think with that particular term you would be able to get your answer. So hears better in noisy surrounding, that is paracusis. Yes, Raghu, you are absolutely right. Next question, I think we have already discussed this and can answer it perfectly. Malignant otitis externa, the answer has to be pseudomonas without any confusion. Yes, Raghu, you are right. Now, a child presented with ear pain and markedly congested tympanic membrane. What can be the diagnosis? Pratik, that is hyperacusis, na? That is hyperacusis. Anyway, everyone is right as far as the answer to this question is concerned, and this is acute suppurative otitis media. And yes, if in this question, if we could have added some words like high grade fever with ear pain and markedly congested tympanic membrane, it is perfect, presentation of acute suppurative otitis media, which is principally seen in children. And here what you need to do, anyone, what you need to do for ASM? See, whenever there is pus formation, if you don't, okay, Raghu, antibiotics will be given, yes, no doubt. But if there is pus formation and if you don't drain it, it will come out automatically by after rupturing the tympanic membrane. So what you need to do? You need to do a myringo. Okay, so give a incision and drain the pus, of course, with antibiotic. But if the pus is formed, work, right? So that is myringotomy. Myringo is tympanic membrane. Tomy means giving an incision, right? So give an incision, let the pus come out, and under cover of antibiotics. If you don't do it, it will rupture, it will perforate automatically. So this is ASOM. Okay, next question, most common cause of stridor in newborn. I think most of you will answer this absolutely right. Yes, Push, you are absolutely. Yes, so this is Laryngomalacia, and you can see a typical, look at the shape of the epiglottis. This is omega shaped. Very typical of, yes, you are perfect. And yes, Raghu, it will resolve spontaneously. So in treatment wise, just reassure the parents because the condition will resolve spontaneously. Yes, perfect. This is related to neonates. And whenever the child inhales, there is, indrawing, you can say, of this epiglottis, and this creates stridor. Okay? So this is the cause of inspiratory stridor in the newborn. Stridor in the newborn. So laryngomalacia. This is good. Sensory nerve supply above the level of vocal cords. Yes, anyone? Suppose this is the level of vocal cords. Above this and below this. Above this is supplied by, yes, Raghu, you are right. This is internal laryngeal nerve, and below this is supplied by recurrent laryngeal nerve. Yes, so yes, Nilesh, you are right. So the answer is internal laryngeal nerve. Now, internal laryngeal nerve, and there is one more. There is one superior laryngeal nerve. It divides into two branches, internal laryngeal nerve and another is external laryngeal. Okay. So internal laryngeal nerve and external laryngeal nerve. Now internal laryngeal nerve is providing sensory supply larynx above vocal cords. And yes, very good, Raghu. External laryngeal nerve is supplying cricothyroid muscle. Okay. So both the two are branches of superior laryngeal nerve, which itself is a branch of vagus nerve. So this is superior laryngeal nerve, which is coming from vagus nerve. Now, why we should know about why I am discussing this external laryngeal nerve here? Because there is a rule for nerve supply of the intrinsic muscles of larynx. And what is that rule? All muscles of the larynx are supplied by recurrent laryngeal nerve, except that exception is cricothyroid, which is supplied by external laryngeal. Clear? Please remember this statement. All the intrinsic muscles of the larynx are supplied by recurrent laryngeal nerve, except cricothyroid, which is supplied by external laryngeal nerve. External laryngeal nerve is another branch of superior laryngeal nerve. Internal laryngeal nerve, of course, is supplying the area from the epiglottis till the vocal cords. This is all supplied by internal laryngeal nerve. So